Okay, it's been a couple of minutes since I've posted anything on the YouTube channel. Usually what I post is testimonials, video testimonials that kind of show the patient explaining in their own words what they have been going through, how long they've been hurting, what they were diagnosed with, what their symptoms are. We do a little bit of the treatment and then follow the patient for several weeks or even months, depending on the complexity of the case, and from there share how the patient is feeling as time moves forward. Today what I want to do is spend a little bit more time on explaining the data and what I'm seeing and how I'm using it and why that's important. I'm going to make this for patients and for other treating doctors who are interested in what they're seeing as far as the trigeminal neuralgia type of a case, okay, whatever that is. So this particular patient has been searching for a while, trying to find an answer as to why she hurts only on the left side, right? And she's gone to ENT, she's gone to doctors, dentists, chiropractic, over and over, just, trying to find anyone who has her answer. So she ended up coming here by a referral of a neighboring dentist who's down the road, and go in for a consult. That's essentially what we did. So you can see that this is today. This is this morning at 9:27 a.m. We take this data, and we did a consult first, went over all of our options, and she elects to do disclusion time reduction therapy. And so that is a splintless therapy for TMD or any of the diagnoses that can follow under TMD, depending on how the patient presents and what this information is. Now, so let's just kind of break this down a little bit. This is bite force distribution on the right and the left, right here. She's got 50.2% on the left, 49.8% on the right. And for all intent and purposes, she is balanced. Like, there's no problem there with her bite being out of whack, right? I mean, overall, some of these numbers, individual teeth, I'm not really thrilled with. But the interesting thing is, even though that her bite force is evenly distributed, what's concerning is the muscle output is not, okay? And if you look at the right here, this is right and left temporalis anterior, right and left masseter muscle. And so you have these two bursts of muscle EMGs with these two bite crushes of the T-Scan sensor, okay? And these colors and the heights of the pixels tell us something about the intensity of the force. Now, what I want to point out to you is the right side, temporalis and masseter, are considerably less than the left, right? Left is hyperactive by double, really. And so if this poor woman gets diagnosed with trigeminal neuralgia, they're going to do a recommended, of course, oxcarbazepine or gabapentin as the first line, see how the patient does. And then, if that doesn't work, well, we do an MVD, or we do an ablation, or we do some sort of gamma knife, right? I mean, those are really the only options. And so it's fascinating to me that her pain is unilateral on the left side. And you can see that the muscles on the left side of her face are behaving differently, okay? So if you've watched any of the other DTR videos or any of the social media stuff that gets put out, when we're doing DTR, you know that there are leads just behind and lateral to the eyes, and then right on the masseter muscles themselves. So we can measure in real time what's going on. And you can also see in the burst that this amplitude is thicker than this one. This is the left, this is the right, and then the same kind of thing happens here. This is the left, this is the right. But the synergy of this is very It's not symmetrical, okay? So the timing of the bite is off, and I'm not going to go through that because that's really not the point of this video. I wanted to show what is possible and what's going on from a physiologic standpoint. So if you only are looking at bite force, well, the bite has nothing to do with her pain because she's balanced. However, the timing of the bite, which is down here, and you can't see on this particular slide, is where we get into some trouble, okay? But I want to show what the muscles are doing. That is the point of this video. So we go ahead and we treat her, and this is her post-op data. Now, the interesting thing here is we didn't turn down the sensitivity, right? So you have a lot of bite force up in this area, and then post-therapy, you have one pink where you might have had like 4 or 5 in the previous one. She's still within my 5 percentage points. I'm not too worried about that at all. But what I want to show you is it's only been it's the same day. It's today, and it's 9:56. So that's 29 minutes. And look at the muscle physiology change. This amplitude and this amplitude are greatly reduced. In fact, if I go back and look at this one particular slide, you'll see that this is 268 and 238. These are in microvolts, by the way. And this is 139 and this is 86 on the right side. So if I go forward, now the left side is at 134 for the temporalis and 76 for the masseter. That is really cool. Okay, so we have a physiologic change going on, and look at the muscles are behaving much more synergistic, much more symmetrical in the burst that they're giving to the patient, right? So the patient says in the chair, well, I feel really relaxed, and this is kind of weird. I've never felt this before. My bite feels even, and I feel like I'm resting, and I really can't clench like I used to. Well, those are all important things. But you can't do that procedure without the EMGs, because that tells you when a physiologic event has occurred. So again, in 29 minutes, this is what we've seen. I totaled up those bars, and the right side has total microvolt burst of 226.4. The left side is more than double at 507.6 microvolts. Post DTR, she drops down on the right to 174.6, and the hyperactive muscle on the left goes down to 210.2. That is significant. It's very significant. It's where all the patients that are talking about the instant relaxation of the face, that's what's going on, all right? So one of the new toys that I have, and I'm always constantly trying to find some new biometric way of measuring to assign a number to what patients are experiencing. One of my new toys is Innobyte, and this is from Cube Innovation. And so what I did was I went ahead and had the patient bite down into the sensor. And what this measures is absolute force. So our T-Scan measures relative force, like from one tooth to the other, right? This measures total absolute force. You measure this, take a pre-treatment recording, and then execute DTR, and then take a post-treatment recording. And then the company supplies these reference values. You can actually find these on their website. I just pulled these off of the web. And the patient, her pre-DTR absolute force is 29 newtons. That puts her down here. Okay? We execute DTR. We see what's going on with the muscles. They're functioning synergistically and better. Now she's at 328 newtons. She's up here. Keep in mind, this is visit 1, and only 29 minutes have elapsed. So, what is it that we're actually seeing with patients that are getting diagnosed with trigeminal neuralgia. I'm not talking about the patients that have had MVD or it self-resolves or they have had the gamma knife surgery and everything is wonderful. The microvascular decompression only accounts for 10% of the patients. What are the other 90% that are being diagnosed with this? What are they suffering from? And that's a challenging thing. I think both dentistry and medicine have some egg on their face. But if we're looking at changes in muscle and patients getting better and feeling better, there's already literature out there besides what I've published that go ahead and coincide with that information. Let's take a look at what I'm actually talking about here. If you go and just pull up National Library of Medicine and go to PubMed and type in trigeminal neuralgia and Botox or botulism, you come up with 88 results. Now, the interesting thing about this is there are about 15 or 17 systematic reviews which have looked at Botox in treating trigeminal neuralgia. Botox is only going to paralyze muscle. It's not going to do anything for neuropathic pain. But instead of rethinking what our etiology is for trigeminal neuralgia and say, hey, you know what, maybe we don't have it right, we start looking at possible neuropathic pain properties of trigeminal neuralgia. And I was trying to find one of those on here, but you guys can go and look at this. So there's quite a bit of evidence that says that trigeminal neuralgia does respond to the Botox. But to be fair, they're not injecting this at the brainstem. They're not injecting Botox at the trigeminal nerve root ganglia. They're injecting it into the muscle, right? And so it's only going to be a matter of time before other people start catching on. Try to use, the Botox for glossopharyngeal neuralgia or occipital neuralgia. Those are both neuropathic pain, and they should respond accordingly. Don't think you're going to have the same results because I think our etiologies are two different things. So I wanted to make this video just to give patients and doctors something to think about. I realize that trigeminal neuralgia is extremely frustrating. I've treated a number of these patients. I'm well above 40 at this point. But you have to be your own advocate, and sometimes the patients have to seek another opinion because doctors can't see the forest from the trees. We're taught one thing, and we never challenge that throughout our whole professional career. And I think we have a lot to apologize for, especially in this group of people. And not medicine so much, but dentistry. It's just my personal belief and opinion that we have abdicated our responsibility to the patients just because we are failing to measure what occlusion really is. And unfortunately, if you don't own one of these, you really can't do exquisite work from an occlusal standpoint. Thank you for listening. That's all the time I have, and I hope this helps some people.